Hello everyone and welcome back on our channel. In this video we're going to be covering our fourth topic in the cardiovascular system pharmacology, and it is going to be about the anti-anginal drugs. Now, the angina is basically this imbalance between the oxygen demand and the oxygen supply to the heart. Now, whenever the heart is working, it is always demanding oxygen, right? And this oxygen is supplied by the coronary blood flow. Whenever the coronaries aren't supplying the heart with enough oxygen for the demand, this is going to cause angina. And you know that the angina is basically this very restricting pain in the chest that can spread to the left arm, to the neck, to the jaw, and it can even spread to the right side as well. Okay? Now, what does the coronary blood flow depend on? So the coronary blood flow depends on the heart rate. Now, when we explain the coronary blood flow, you should know that the coronaries are filled with blood when the heart is in diastole, not in systole. So whenever the heart is in systole, the coronary blood flow isn't going that good. It may be even diminished totally, right? So because the heart is contracting, the coronary blood flow is going to decrease. But in the diastole, the heart is resting, so the coronaries can fill up and can supply the heart with blood again. So if you increase the heart rate, this actually means that the diastolic time is going to decrease. If you decrease the diastolic time, you're going to decrease the coronary filling, right? So the coronary arteries filling is going to decrease if you decrease the diastolic time. So that's why we care about the heart rate in determining the coronary blood flow. The coronary blood flow also depends on the diameter, of course. So if the diameter of the coronary blood flow of the coronaries was decreased by an atherosclerotic plaque, or for example by a thrombosis or by an emboli, this is gonna all decrease the area, the diameter of the coronary where the blood should actually be going to the heart, and this is gonna decrease the coronary blood flow. I think this is totally understandable. Now, the third one is the perfusion pressure. So, the coronary blood flow, the coronaries are connecting the aorta with the ventricle, right? So it is connecting, so they are originating from the aorta and they are going to go to supply the ventricles, okay? Now, the pressure difference between the ventricle and between the aorta is going to determine the perfusion pressure. How can we understand that? It is basically like every other material, it moves from the high pressure to the low pressure, right? So basically, for example, when you're doing expiration, you contract your muscles, your respiratory muscles, in order to increase the pressure in your chest, so you expire the air out. So high pressure to a lower pressure. Now here it's totally the same. So the blood is going to move from the high pressure, which is in the aorta, towards the towards the ventricles through the coronaries, because the ventricles should be in a lower pressure in the diastole, right? That's why the coronaries are filled in diastole, because it depends on the perfusion pressure. Now, the fourth thing is the ventricular wall stress. Whenever the stress, the wall stress is increased, so whenever the ventricles walls are in stress, the coronary perfusion is decreased. Now, what does the wall stress mean? So we have systolic ventricular wall stress and we have diastolic ventricular wall stress. Now, the systolic ventricular wall stress depends on the afterload, while the diastolic wall stress depends on the preload. The preload is the exact amount, it is like exactly saying the end-diastolic volume. So the end-diastolic volume of the heart is going to determine how much the ventricular wall is going to stretch out, right? And this is going to generate a stress against the wall. And if the stress is high, then the coronary circulation is going to decrease. Okay, so four factors: the heart rate. If the heart rate is increasing, the blood flow of the coronaries is decreasing. The diameter. If the diameter is decreasing due to an emboli or thrombus or due to atherosclerotic plaque, the blood flow is going to decrease. And the perfusion pressure. If the pressure difference between the aorta and the ventricle decreased, then the perfusion is gonna decrease as well. But if the pressure difference is huge, like saying, for example, at diastole, the aortic is gonna be like, the aortic pressure is gonna be 60-80, right? While in the ventricle it is gonna be like a 5 to 10. So this is a huge difference in the pressure between the aorta and the ventricle, and that's why it is gonna maintain the coronary blood flow in the diastole. And the ventricular wall stress, if it increases, then the coronary blood flow decreases. Now, so we need always a kind of equilibrium between the oxygen supply and the oxygen demand in order to maintain the function of the heart. Now, what are the types of the angina? We have the stable, the unstable, and the transmittal angina, or some people call it the variant angina. Anyway, so let's start with the stable angina. Now, so as you know, the stable angina is the presence of something that is decreasing the diameter of the coronary artery. So it is always there. It doesn't like just jump up and present there. It is like not a very acute case. It is an atherosclerotic plaque. So it develops with time. It decreases the diameter of the coronary. So it is decreasing the perfusion of the coronary artery. Now, so let's say that this patient has had a heart rate of 70 beats per minute. 70 beats per minute, right? Now, actually this blood supply that is actually lower than the normal due to the presence of the atherosclerotic plaque is still enough for a 70 beats per minute. So the patient doesn't have pain when he is resting. Now, the patient got up and started walking or started going up the stairs or whatever activity. Now the heart rate is accelerating, right? It is increasing. Let's say that the heart rate has reached 90 or 100, okay? Is this blood supply enough for a heart rate of 90 or 100? No, it is not enough. So at this range of heart rate, the patient is going to get pain because the oxygen demand of the heart has increased because we increased the heart rate. But the oxygen supply didn't increase because there is an atherosclerotic plaque blocking the way of the blood to the heart, right? So he's going to get pain at a certain level of exertion. So the stable angina doesn't develop pain at resting, but at a certain level of exertion. Now, on the other hand, the unstable angina, if we thought about the atherosclerotic plaque, if it ruptured, this is going to lead to coagulation of the blood on the top of the atherosclerotic plaque. So the platelets are going to come, the platelets are going to accumulate here, and then there is going to be fibrin deposition, so coagulation process, and this is going to get bigger. Now, if this got bigger, but there is still a little bit of perfusion in the coronaries, it has, so basically the perfusion of the coronaries has decreased, but it is not zero. It has decreased so much before the comparing to before this coagulation. So the unstable angina can happen at resting. So even if the patient is resting, the atherosclerotic plaque may rupture, or an emboli can come and even increase the blockage of the coronary artery and further decrease the coronary blood flow. And this can lead to a sudden pain even at resting. And this is the unstable angina. Now, the transmittal angina, which doesn't have a clear explanation, but it is this sudden vasospasm of the coronary arteries. So as we know that every artery has a smooth muscle, right? So the coronary artery, all of a sudden, it just contracts. It is a vasospasm of the coronaries that is decreasing the perfusion to the heart. It may be explained that this patient may have a high number of the alpha-1 receptor in the smooth muscles of the coronaries that is exerting like a lot of vasoconstriction all of a sudden. Okay, when does the transmittal happen? Does it happen at rest or at exertion? It can happen anytime, even if the patient is sleeping. Okay, so now we know the types of the angina. Let's move to the treatment. How can we treat the angina? Our main topic, so the anti-anginal drugs, we're going to focus a lot about the organic nitrates, but let's leave them for later. Then we have the calcium channel blockers, and we have the beta blockers. So if you have watched my video on the calcium channel blockers, we have explained that we have the Verapamil, which is basically cardioselective, cardiac muscle selective, and we have the DHB, which is the dihydropyridines that are smooth muscle selective, and we have the diltiazem, which is not really selective. It can act on the cardiac muscle and on the smooth muscle. Now, let's actually see the Verapamil. Can we give the Verapamil to a patient with a stable angina or unstable or transmittal? We can give it only for patients with a stable and unstable. Why? Because it is acting on the heart. It is going to decrease the heart rate by decreasing the automaticity of the sinoatrial node, and then it is going to decrease the conduction in the atrioventricular node, and then it is going to end up decreasing the heart rate. If we decrease the heart rate, this actually means that we are decreasing the oxygen demand, right? This is one hand. On the other hand, if we decrease the heart rate, actually we're increasing the diastolic time. If we increase the diastolic time, we're increasing the oxygen supply as well. Okay, let's come to the transmittal angina. Why wouldn't we use the Verapamil for a transmittal angina? The Verapamil is not gonna act on the smooth muscle of the coronary arteries. It is not gonna do vasodilation of the coronaries. And our main problem in the transmittal angina is the vasospasm. So the Verapamil is not gonna help it here, right? So we only use the Verapamil for the stable and the unstable angina. But as you know that we've mentioned in the calcium channel blockers video, that the Verapamil can be used for the tachyarrhythmia, for the tachycardia, for the re-entry. Yeah, let's just leave it. Now, let's move to the dihydropyridines. We said that the dihydropyridines are smooth muscle selective. Now, they are not cardiac, they are smooth muscle selective. Where are the smooth muscles that we're talking about? In the arteries, okay? Let's take the nifedipine as an example here. So, the main function of the dihydropyridines is to decrease the vasoconstriction. So there is already a vasoconstriction present, and we're going to decrease this vasoconstriction, leading to vasodilation. If we do vasodilation, this actually means that we are decreasing the total peripheral resistance. And what does the total peripheral resistance represent? It represents the afterload. Now, if we decrease the afterload, this actually means that the heart doesn't need to work that hard, right? So we can decrease the oxygen demand of the heart because we're decreasing the afterload. The heart doesn't need to work that hard anymore. And that's how the dihydropyridines work. Okay, is it only that? No, but it is also a vasodilation in the coronaries. This is a direct vasodilation in the coronaries. Okay, so we increase the perfusion in the coronaries by using the dihydropyridines, and so the end result of the dihydropyridines is decreasing the demand by decreasing the afterload and increasing the supply by vasodilating the coronaries. Okay, now for what type can we use for what type of angina can we use the nifedipine? So the nifedipine can be used for the transmittal angina, because we said that the main problem with the transmittal angina is a vasospasm. If we vasodilate the coronaries, we solve the problem, right? So that's the main use. And if we use the nifedipine for a patient who has a stable angina, we may make things worse, right? So how does this happen? If we vasodilated the peripheral arteries, so we're basically decreasing the blood pressure in the periphery, right? Now, if we decrease the blood pressure, this is going to lead to a reflex tachycardia. And the reflex tachycardia is going to further increase the oxygen demand on the heart. And this is going to just make things worse because we already have a vasospastic coronaries. So now the supply isn't enough and the demand is increasing. So that's why if we were to use the nifedipine for a stable angina, we should be really, really careful with the dosing. Otherwise, a reflex tachycardia is going to happen, and this is just going to make things much, much worse. Okay, and the diltiazem, I don't know whether it's used actually practically like as an anti-anginal drug, but yeah, like technically it works. Now, let's move to the third category. It is going to be the beta-1 selective blockers, the beta-1 adrenergic receptor blockers. Now, as you know, that here in this category we have the Atenolol, the Betaxolol, the Bisoprolol, the Celiprolol, Metoprolol, and Nebivolol. Now, if we use the beta-1 adrenergic receptor blocker, what we're going to do is two things. We're going to do a negative ionotropic effect, decrease the contractility of the heart, decrease the force that the heart is contracting by on one hand, and on the other hand we're going to decrease the chronotropy. So a negative ionotropy and a negative chronotropy. What is the negative chronotropy? It is decreasing the heart rate. Now again, if we decrease the heart rate, we're decreasing the demand on the heart on one hand, and on the other hand we're increasing the diastolic time, right? So let me write this here. Diastolic time. Diastolic time. So if we decrease the heart rate, we're going to increase the diastolic time, and we're going to increase the coronary blood flow and increase the supply. So the end result, we're decreasing the demand by decreasing the contractility and the heart rate, and we're increasing the supply. Okay, now can we use actually a beta blocker together with verapamil, for example, for a stable angina? No. Why? Because it is an interaction. What type of interaction? It is the so-called additive interaction. Additive. What does it mean, additive interaction? So in pharmacokinetics, additive means that the sum of action of both the drugs is going to be higher than either of them. So if we use the beta blocker and the calcium channel blocker together, this is going to exert so much depression of the heart function than if we used only one of them. So if we used, for example, calcium channel blockers and we decreased, let's say, the heart rate from 100 to, let's say, 80, okay? And we used the beta blocker alone and we could decrease the heart rate from 100 to 60, okay? So we have from 100 to, I don't know what did I mention, 80, yeah, to 80 in case of the calcium channel blockers alone. And we have it from 100, let's say, to 70 in case of the beta blockers. So the decrease here is 30, right, in case of the calcium channel blockers alone. And in case of the beta blockers alone, it is going to be, sorry, here 20, and here it's going to be 30, yeah? Now, if we use both of them together, we may decrease the heart rate by 40. So from 100, we're going to decrease it to 60. Now, the decrease is actually greater. The decrease is greater than either of them, but it is not greater than the sum of them. So the sum of these is going to be 50, right? But 40 is smaller than 50, which means that the sum is still greater than this.
Sorry guys, here just one thing that I forgot to mention is that I wrote others, as you see it, just underneath the how to treat. And by this I actually meant that we give antiplatelet agents as well as lipid-lowering drugs and ACE inhibitors to any patient who develops angina. Now, the antiplatelets are important because we need to inhibit any thrombosis that may develop, and the lipid-lowering drugs is also important because it is going to decrease the atherosclerosis, and the ACE inhibitors are important to decrease the risk of any myocardial infarction that may happen. So all of these drugs are kind of a preventive for any more angina to come.
Now, our third group of the anti-anginal drugs is the organic nitrates. Now, the organic nitrates is a group of drugs that are gonna end up forming the nitric oxide in our body. Okay? All of these drugs are prodrugs. None of them is an active drug. So, we take the drug and it is gonna be converted to the active form of it, which is the nitric oxide in our body. Now, how does this happen? This needs an enzymatic activity in our body in addition to reduction. The reduction of the prodrug happens by the help of a thiol group, so the SH containing compounds like the cysteine or the glutathione. So when these processes happen, this prodrug is going to end up forming the nitric oxide. Now, the nitric oxide is outside of the cells. The nitric oxide is lipophilic, so it can just diffuse through the membranes of the cells. It can diffuse through the cell. Okay, so you can imagine that this area is inside the cell, and in this case, what cell we're talking about is basically the smooth muscle, because what we're talking about is the vessels and the smooth muscles of the vessels. So the nitric oxide is going to diffuse through the membranes of the smooth muscles that are lining the vessels, and they are going to meet an enzyme called the guanylyl cyclase. This enzyme is intracellular enzyme. It is not on the surface membrane, it is inside the cytoplasm. So the NO, the nitric oxide, it's gonna activate the guanylyl cyclase, and when the guanylyl cyclase is active, it is gonna convert the GTP into cyclic GMP. Now forget about this part. It is gonna convert the GTP into the cyclic GMP. Now what does the cyclic GMP do? The cyclic GMP is gonna activate an enzyme called myosin light chain phosphatase. Now, as you know, that if the muscle fiber, the myosin, is phosphorylated, so it is a myosin light chain phosphate, then the muscle is actually in contraction. Now, if we remove this phosphate from the myosin light chains, this is going to lead to relaxation, and this is the function of the myosin light chain phosphatase. So, this enzyme is activated by the cyclic GMP, and it is going to remove the phosphate group from the myosin light chain heads. This is going to end up relaxing the smooth muscles of the vessels. And we know that when the smooth muscles are relaxed, then the diameter of the vessel is going to increase, which means vasodilation is going to happen. Okay, so if we give a low dose of the organic nitrates, it is going to act more on the veins than that on the arteries. Now, if we dilate the veins, so venodilation, this is going to decrease the preload on the heart, because we're decreasing the end-diastolic volume, right? When we decrease the end-diastolic volume, we decrease the preload on the heart. If we decrease the preload on the heart, we actually end up decreasing the oxygen demand on the heart, right? This is the first thing. Now, what happens if we increase the dose a little bit? What is going to happen is further venodilation and some arteriodilation. Now, what does arteriodilation mean? It means that the total peripheral resistance is going to decrease as well. And the total peripheral resistance, it represents the afterload. So the afterload is going to decrease too. Now the afterload is going to decrease as well. And if we decrease the afterload, in addition to the preload, we're further decreasing the demand, the oxygen demand of the heart. So this is the mechanism of action of these drugs. Now, what is the difference between the organic nitrates and all the other types of vasodilators, any other drug that has an effect on vasodilating? For example, when we speak about the dihydropyridines, so we mentioned before that the dihydropyridines are vasodilators because they act on the smooth muscle, right? Now, what is the difference between the organic nitrates with the dihydropyridines? Let me explain this drawing first. So area A and area B are both parts of the heart, okay? And these red lines are vessels that are supplying these parts of the heart. Now, area A is totally intact. We don't have ischemia. It is not the cause of angina. But on the other hand, the B area, it has an ischemia due to some narrowing in the coronary. It can be atherosclerosis or whatever cause that is leading to the angina by this ischemic area. Now, we know that in the ischemic area, there is going to be a high accumulation of the carbon dioxide, right? Because we don't have a proper circulation in this area. Now, the carbon dioxide accumulating here is going to lead to vasodilation. This part, the end part here, it represents the arteriole, so the end part of the artery. Now, so area B is ischemic area due to a coronary defect. There is atherosclerosis or any other problem that is leading to ischemic area of the heart, and it is the cause of the angina. So we said that the carbon dioxide is going to build up here, and it is going to lead to arteriolodilation. So the arterioles are going to dilate. Now, what happens if we gave any vasodilator, not the organic nitrates, What is going to happen that these vasodilators are going to act on the smooth muscles, mainly in the arterioles. So they are going to further dilate this part, they are going to make it bigger, and they are going to make this even bigger. Now, is this going to solve the problem? No, it is not going to solve the problem, because the problem is here. It is not in the end arteriole, right? So the arteriole was already dilated here. So it wasn't our problem. That's why we came up with the organic nitrates. What do the organic nitrates do? So the organic nitrates are going to lead to the dilation of the collaterals. So there are everywhere, there is connections between the different branches of the vessels. This collateral artery, it is connecting this intact area with this defective area, okay? Now the organic nitrate is going to come here, and it is going to further dilate this collateral, so the supply is going to come from here to this ischemic area. Now the circulation is going to be much better than before, and we solve the problem. That's the main difference. This is a very important point about the organic nitrates, that it is dilating the collaterals. Now, so we said that if we used a different vasodilator or any other vasodilator other than the organic nitrates, it is gonna dilate this area, right? The arterioles, and it didn't solve our problem. But it is what is gonna happen in that case, that actually the blood is gonna further come here, because you actually dilated the arterioles in the intact areas more than that in the ischemic areas. And this is gonna basically make the blood further go to the intact area. And this is gonna make things worse, and it is the so-called Steele syndrome. It is a Vaso-Steele syndrome or something like that. Okay? So that's why the organic nitrates solve the problem differently, and it dilates the collaterals and brings the blood from this collateral to the ischemic area and solve the problem. Now, what other advantages do the organic nitrates have? Is basically relieving the vasospasm. So if this actually narrowing of the coronary artery was because of a vasospasm, this is going to be solved by the organic nitrates too. So the prensometal angina can also be solved by the organic nitrates. Now, inhibit the platelet aggregation. So if the problem was basically thrombosis, coagulation, inhibiting the platelet aggregation is an advantage of the organic nitrates. But it is not only acting on the smooth muscles that are present in the coronary arteries. It is not specific. It can't just go to the smooth muscles of the coronary artery, but it is going to act on all the smooth muscles that are present in our body. So we expect some smooth muscle dilation in the GI and in the bronchi as well. And it has a positive lusitropic effect on the heart. Lusitropic, it means that it further increases the relaxation of the heart. So this is going to actually make the heart function better in case of an angina patient. Okay, just one thing that I forgot to mention, we spoke about the mechanism of action of these drugs, and how does the NO end up causing relaxation, right? Now, the cyclic GMP that has been produced here by the guanylyl cyclase is gonna be, after all, degraded, right? So we need to get rid of it. And this is the function of an enzyme called the phosphodiesterase. So this phosphodiesterase is going to convert the cyclic GMP into GMP, which is totally not active. Right. Now, if we apply the drug that is called the sildenafil. Now, the sildenafil, whether you know or not, it is the Viagra. Okay, so I think everybody knows the Viagra. Now, so the sildenafil is going to block the phosphodiesterase enzyme. So what happens if we block the phosphodiesterase enzyme? This means that the cyclic GMP is going to accumulate, it is not going to be degraded, and the action of the nitric oxide is going to be prolonged, so it is going to act for a longer time. So this is a definitive contraindication. So we can't give a sildenafil or a Viagra to a patient who's receiving organic nitrates. Okay? Now, let's go to the tolerance. The problem with the organic nitrates that they develop tolerance. What do we mean with the tolerance? That after applying the drug for a period of time without like a windowing, it is like, for example, so we have 24 hours in the day. Within 12 hours, you should take all the doses recommended, and in the other 12 hours of the day, it should be a rest for the body. This way, we wouldn't develop tolerance to the drug, so the drug would still be functioning every day. But if there was a continuous exposure to the drug, there is going to be tolerance developing. So the drug, after all, is not going to be functioning anymore. Now, how can we explain this? So, at the beginning, we said that the organic nitrates are all prodrugs. They need to be converted into the nitric oxide. And we said for that, we would need a thiol group, the cysteine and the glutathione. What if we consumed almost all the thiol groups in our body? So this means that we wouldn't be able to convert any more organic nitrates into the nitric oxide. So tolerance can develop. But tolerance can also develop if the compensatory processes started working. So we know that the nitric oxide is going to cause arterial dilation, right? So this means that the blood pressure is going to drop a little bit. This can evoke a reflex tachycardia. So if the reflex tachycardia worked, we're not going to see an organic nitrate effect, because the oxygen demand of the heart is going to be rising up again. Now, the third problem that can cause the tolerance is oxidative stress. If the body was in oxidative stress, this is going to lead to the degradation of the nitric oxide. So the nitric oxide is going to be produced, but it is going to be degraded right away due to the oxidative stress. Now, let's see the people who work in factories and they are exposed to nitrates all the time. So, from Monday to Friday, they are being exposed to nitrates, they develop tolerance, there is no change over the week because they smell the nitrate, but they are addicted, so they don't react to that, okay, because their bodies are used to it. Now, the weekend started, Saturday, Sunday, they didn't work. They weren't exposed to nitrates. The tolerance is gonna just go, it is gonna cease. Now, on Monday, they started working again, they are exposed to the nitrates again, but they don't have tolerance anymore because it disappeared during the weekend. What is gonna happen in the morning of the Monday, what is gonna develop is an effect of the nitrate. So there is gonna be venodilation, arterial dilation. What is gonna happen is that they are gonna develop headaches because there is gonna be dilation of the meningeal arteries. They are gonna develop flushing. This is dilation of the cutaneous vessels, and orthostatic hypotension because the arteries are dilated, and reflex tachycardia. Forget about the methemoglobinemia because the methemoglobinemia is a side effect of a chronic, very long use and exposure of the nitrates. But what we're talking about now is the Monday morning disease. So it is a disease, or it is a sickness, a morning sickness that happens in these factory workers in the mornings of Mondays because they are exposed to nitrates again after the tolerance has already gone during the weekend. Okay, now let's see what drugs do we have in this category. Now the first and the mainly used one is the nitroglycerine, or it has another name, the glyceryl trinitrate. Now, this guy is very famous in pharma because it has a very, very high fast-pass metabolism. So if you give this drug orally, the liver is going to consume most of the dose before reaching the systemic circulation. And this is not going to give a beneficial point of this drug, right? So because of this very high first pass metabolism, we would rather apply this drug sublingually as a spray or sublingual tablet, and there is a transdermal patch that is more commonly used. So we can use this nitroglycerine in these forms. Its half-life is 3 minutes only, and the elimination of it is gonna at the end happen in the liver as well by an enzyme called the hepatic glutathione S transferase. Okay, now let's see the other drug here is the isosorbide dinitrate. The isosorbide dinitrate, it has a longer half-life than that of the nitroglycerine. Actually, its half-life would be closer to 45 minutes or 1 hour. Now, can we give this orally? Well, yeah, we can give it orally, but still, it's better given sublingually. Why? Because it has first pass metabolism, but it is much less than that of the nitroglycerine. Now, during the first pass metabolism of the isosorbide dinitrate, it is going to be converted to isosorbide mononitrate. Okay? Now, we have actually a third drug that is the isosorbide mononitrate. So if we give the isosorbide mononitrate to the patient, it is not going to have any further first pass metabolism. So this means we can actually give it orally because its oral bioavailability is going to be really high since it is not going to be degraded to any further metabolites, right? This is the isosorbide mononitrate given orally. Okay, then we have the amyl nitrite. Okay, amyl nitrite is not used anymore. It is totally obsolete. Why? Amyl nitrite was a drug that you basically need to put on a cloth or something and then smell it. So it is like you just inhale this drug, right? And this drug is totally volatile. So yeah, it is extremely volatile, and that's why it was withdrawn and it is not used anymore. Okay, now what are the uses of the organic nitrates? What are the indications? So our topic is anti-angina. So it is mainly used in angina, but we can also use it to relieve the symptoms of the myocardial infarction. We can also use it in case of the heart failure, since it is going to decrease the preload by the venodilation and decrease the afterload by the arterial dilation. And we can also use it in case of the hypertensive crisis as well. Yeah, I think that's all for the anti-anginal drugs. I hope you guys have enjoyed this video and see you in the next.